So the first thing on our agenda is a brief review of the last meeting. We haven't met in a little while, but in the last meeting, we discussed multi-bedrooms and whether or not they should be phased out and how. And we discussed additional information that acquiring nursing home acquirers could provide for additional oversight. Does anyone have anything to add to the meeting minutes that were sent out, or anything additional they want to say before we move on? All right, thank you. So we will dive right in. Actually, Ben, did you want to say anything before we start?
Again, I apologize for the delay, but we're now in operation. So Stacy, go ahead.
All right, thank you. Okay, so we'll dive right in. Everybody has a copy of the draft report. We sent that out a little over a week ago. And so recommendation number 1 is on the screen now, and it has to do with before the acquisition happens. So recommendation 1 says that the MHCC staff shall provide a MHCC report and recommendation to the OHCQ and the Office of the Attorney General for each proposed nursing home acquisition. The finding and recommendations required under Health General 19-11583 shall include a summary of the findings and the basis for recommendations. And to implement this recommendation, commission staff will write a report including the following data for each nursing home acquisition. The report will include Maryland facilities and non-Maryland based facilities if appropriate. So the additional 6 items are the most recent Centers from CMS overall 5-star rating, the results of a PACER report, including a review of court cases for any violations of the Federal False Claims Act, the status of the Office of the Inspector General Exclusions Program, the status or existence of a memorandum of understanding with Medicaid, and the percentage of Medicaid patients served in comparison to the threshold in both the jurisdiction and the health planning region, the overall rating of satisfaction, and the percentage who would recommend the nursing home measures from the most recent results of MHCC's Nursing Home Family Experience of Care Survey. And finally, the special focus facility and abuse flag status in the most recent refresh for CMS and Medicaid service. I'm sorry, the Centers for Medicaid and Medicare and Medicaid Services Care Compare data.
Okay, so we did receive a couple of responses already, so I'll just be interjecting with what those are. So for this one, we have just one, and it says that the list of A through F here is that it's a comprehensive source of data. So that was the one comment that we received in recommendation number 1, but I will pause for a moment to make sure that there aren't any other comments for this one, that there's anything else here that we want to add for this pre-acquisition step.
Oh, I'm sorry. Stevan has a question. How would this be different from the change of ownership and the certificate process?
Some of the measures that are on here are things that we are currently already reporting, and some of the measures on here are things that are new. Definitely the inclusion of the family satisfaction survey is a new metrics, and then adding the special focus facility and the abuse flags, those are also new metrics. So this would be in conjunction with what we are already currently doing, and we're going to get to that in another recommendation, but this will be in conjunction with the monthly report that's already being taken for the commissioners prior to each commission meeting each month. Does that answer your question, Stefan?
Yes, thank you.
Oh, you're welcome.
So I just want to interject one point here is that the parallel with the certificate of need process is that there is a determinative vote on the part of the commission itself. These would be reports that would be submitted to other entities in Maryland government, but the Healthcare Commission would not based on this recommendation, take a vote per se. Is that correct, Jean Marie?
That's correct.
So I think it's quite different than, what would typically occur in a CON process.
Correct, yes.
I did have a question about, could you expand on what it means to, the reports will include both Maryland and non-Maryland based owners and operators? Would we be agreeing to look at for a acquisition where there are both Maryland operations and non-Maryland operations? In that case, we'd look at everything.
So normally for a CON process for Maryland facilities, we would just look in Maryland unless there were no operations in Maryland. And then, if there were not operators in Maryland, then we would look outside of the state. And we wanted to generally follow the same principles here, although the way that this is written, you'll notice that we have the words if appropriate. So we can certainly imagine, reviews where I think the example had come up where perhaps there's like one Maryland facility and then there's 100 facilities that are in other states. In that type of scenario, we might want to take a look more at what's out of state as well.
Thank you. 100 would be quite a resource intensive enterprise.
It would be, yes.
Senator Bidel has her hand up. You're on mute.
Unmute. You think I know by now. Good morning, everyone. Thank you. I just want to be clear. Are we going to be looking at their operations in other states if they are coming to this state as a first-time buyer? I mean, I think their overall management of nursing homes is important, especially if they're coming to Maryland as a new owner.
If they're brand new and they've never operated in Maryland before, we would look at all of their operations in all of the other states.
Thank you.
See any additional chats or hands up? We'll move to the next one. Okay, recommendation 2. Commission staff shall continue to provide information on pending nursing home acquisitions in the Maryland Healthcare Commission update of activities. This update will be provided to commissioners monthly for each commission meeting and posted on the commission website, and will include the MHCC report and recommendation if completed.
And then for this recommendation, we did receive 2 comments already. And certainly you can feel free to, if you would prefer to, say your own comments. I know I can see Anna is on the call with us. Did you want to go ahead and read your own, Anna, or would you want me to read it?
I'm happy to read it. So,
Okay.
and this has been an issue I mentioned in one of our earlier meetings, that if there's a clear commitment to transparency, that means transparency to nursing home patients and their families, all of whom may not be able to attend commission meetings or have access, excuse me, to the internet or website. So I just want to make sure that patients and families are aware that that their nursing home may be in a status of being acquired by another entity. And I'm not sure that's going to happen. So that's my concerns. Thank you.
And the second comment we had was from Ann McKay. Ann, are you on with us?
Yes, I am.
Do you want to go ahead and share your comment? Or did you want me to? I have it here if you want me to read
Yeah,
it.
go ahead, please.
Sure. What Ann McKay has shared is that she said that we should be highlighting nursing homes that operate with or are affiliated with a continuing care retirement community in the Healthcare Commission update of activities. Other than those 2 comments to the recommendation, are there others on the call who have additional comments that they would like to share? No?
So in terms of the recommendation that information be made available to patients, and families. Have we thought about that?
You know, we have this comment that came in, and actually we have another comment coming up in a few recommendations. So it's come up multiple times, so we might perhaps consider we could consider a publication, you know, how we would do for a CON in the Maryland Register, in the local newspaper, some sort of notification so that the facilities and the family members have an opportunity to know what's going on if they're unable to attend a commission meeting. It's an idea.
So maybe this is, well,
Why don't you identify yourself?
Tracy DeShields with MHCC. So what would people do with this information?
I think it's mostly so that people are informed about it, and then, you know, they have the option, you know, to reach out to, you know, their representatives or to the facility management, you know, if they have questions or concerns.
This is about transparency.
Hmm?
Transparency.
Transparency, yes.
And we don't typically, although I suspect these notices that we currently put in the commission update, we don't routinely make those available to the purchaser, although we believe that purchasers do review that information.
Correct. I mean, they are on our website, but we don't actually send it, you know, send it to them now. Yes.
Senator Vital has written in the chat a question. So will a letter go out to the family members telling them when an acquisition is pending?
I'm not sure about that, but we can circle back on that comment, Senator.
And Stevan, I
Thank
see
you.
you have your hand raised.
I do like the idea of letting residents and families know that this process is happening. There have been so many changes of ownership since certificate of needs, well, more change of ownerships. And I know that it can be very confusing for residents and families. So for them to be informed, and if there is a public meeting, if they'd like to participate, I think that would be fantastic since it is their home. Oh, sorry about my phone. The other unrelated issue is as far as a recommendation, in some states, the state ombudsman actually gives feedback or is involved in the pre-acquisition and the post-acquisition phase of a nursing home changing ownership or starting from the ground up. So I just wanted to offer that, and I could find out more about that, how it's done in other states. But I think that would be helpful as well, again, since, you know, the ombudsman program is an advocacy program for residents, and they may have information to share or may have information about the current facility related to even sharing information with the residents and families. So that's my comment.
Thank you, Stevan. That's a good suggestion.
So on that note, with regard to the information going to the purchaser or requiring something to be sent to families and patients in the nursing home, could we make a recommendation that not only the seller, but the purchaser has to provide information about the impending sale to patients and their families?
We could consider that.
Yeah, we can consider.
Yes.
Shykoff, you have your hand up?
Yeah, hi, Izzy Shykoff, Maryland Department of Aging. Can you hear me?
Yes.
Yes.
Yeah, so I wanted to point out something I think it's important in the recommendations on this, and that is that my understanding from OHCQ, from the executive director of OHCQ, is that she has been delegated the authority by the secretary of the health department to make these determinations on transactions. And that, according to her, she does not believe that the new law gives her any additional legal basis to deny licenses. And so, to me, it kind of begs the question, what are we doing? If the recommendations provided by the commission, whether to support or deny, a new or pending transaction does not provide the secretary with additional legal basis, then we're not meeting the spirit of the new law. And what language would allow for a legal basis for the secretary to deny purchases of facilities?
So
This is
I-
Tricia May.
Dr. Nay is saying.
Yeah, sorry, I'm on the phone and couldn't raise my hand. So Izzy, that's something the Attorney General's office is looking at. I don't think this is the people on the call to determine that. So they're looking at that very issue about what the legal basis was required for it and whether this changes anything. So I think we'll defer to the AG's office for that piece.
You mean the AG would make a determination about whether the language in the existing law, the new law, gives you legal basis, or if there needs to be changes to the law? Is that what?
They're looking at both those issues.
So I mean, one additional option is, since these are recommendations that would go to the legislature, is the legislature could clarify that the reports generated by MHCC have to be considered in a licensing decision.
Well, it's not that I think is the problem. It's the ability for OHCQ to deny an acquisition. So, I mean, that could be the recommendation as well, that could be clarified in law, that OHCQ and the secretary does have the authority to deny an acquisition.
Thank you. Ann McKay, you have your hand up.
Yes, I have a question about, from a consumer point of view, this helps a little bit, but it doesn't get at a nursing home that changes ownership. And then you find out later that they own 150 nursing homes in other states, and they have a 1-star rating in these other states. And then you find out that the owner has been brought up on, civil penalty fines and lawsuits in other states. Where would that be addressed in these proposals? For instance, look at Copper Ridge, which it's difficult. If I was a family member looking for a nursing home, or I was a resident in that nursing home, you find out that a new company has 1-star ratings. The facility is now a 1-star rating. And then you try to find out, well, who's the owner? And it's very difficult. I spent 2 hours researching one particular community and found out that there were lawsuits in other states. And it's quite disturbing.
Yeah,
There's not an easy way for a family member or a resident to do the research to find out really what's going on.
Hi, this is Winnie Hawk. I'm with the Maryland Healthcare Commission. I think that we're getting into, I think there's a recommendation further down, but I think what we're really talking about is the timing of these decisions. I mean, by the time it gets to OHCQ, the decision is whether or not to license. The transaction has already occurred. So should there be something on the front end, by the time they get to the licensing stage, the investment has been made. And I can recognize how that's a difficult decision, but it seems to me like that's really what we want to focus on, the timing of when these decisions are made. Because that's when, I mean, the Maryland Healthcare Commission, when we talk about the monthly report, and all of those factors, those A through D, whatever the previous recommendation, we do review all of that information and we have it prior to the transaction. So I think perhaps that's what I think if I didn't capture that correctly, then please correct me. But I think that's where the issues may lie.
Thank you. Okay, I don't see any additional questions or comments, but we've recorded everything that has been commented on so far. I'll move to number 3. So this is a recommendation for post-acquisition. The commission staff shall update the commissioners regarding the progress of each nursing home acquisition for 2 full years after the acquisition date, using the nursing home acquisition follow-up report to collect data on recently acquired nursing homes in order to study the trends and inform future policy decisions. So in this report, MHCC will include an update of the metrics previously included on the MHCC report and recommendation. Additionally, the nursing home acquisition follow-up report will contain the following metrics: progress toward reduction of multiple bed rooms, so that's 3 or more beds per room, the net operating revenue, total operating expenses, net income, total direct care staffing, full-time equivalents, and hours of bedside care per licensed bed per day. The acquiring entity shall submit the above information in the form of a end of year financial statement 90 days after the fiscal year end. The statement should compare the facility performance to its operating budget at the end of each fiscal year for the first 2 years after the acquisition date. Failure to comply with providing this information to the commission will result in the acquiring entity having to appear before the commission and report on its progress publicly. Senator Bidel has her hand up.
Thank you. So my question is, we are depending on this company, this private equity firm that bought it to give us this report. So how can we depend on the accuracy and honesty of the report if we're not doing audits from the state?
So in order to get the information timely, we would be looking at the financial statements that would come from the facility. In order to, I think what you're suggesting would be more of like what we would call an audited financial statement. And the issue there is certainly we could look at that as a suggestion, but the issue is that when you do that, it does take longer to get that information. It's not going to be as close to real-time information, but certainly we can write that down as a comment and a possibility, a good suggestion.
Thank you. I just have a great deal of concern about how they, they come in and they have all these different companies. It's not just the nursing home, it's the property, it's the vendor, it's the equipment provider. And I just don't know if we can get enough transparency from these recommendations. And that's my concern. Thank you.
This is Howard Solins. I'm having trouble finding my hand raising. At the appropriate time, I have a question.
And Lou Grimmel has his hand up.
Yes, the follow-up status reports to the commission should continue for 3 years, not to propose 2. Further, the first bullet point should clarify that the acquired facility should have a 3-year drop dead period to have eliminated at least 10% of its triples and quad bed configuration by means of implementing a renovation project or relocating the affected beds to other comprehensive care facilities with common ownership or control, or by such other means approved by MHCC.
Thank you.
Howard Solins.
Thank you. I think before these recommendations are final, you might want to have a conversation with about some of these bullet points, because there's kind of duplication and lack of clarity. Net operating revenue and net income read like the same thing, and total operating expenses versus net operating revenue. It just, I don't want to, I'm not an accountant, I hang around with them, but it just, I understand that there's a desire to understand what the financial resources are. I'm not getting at that issue. I'm just saying these particular recommendations could benefit from a conversation with somebody with a financial background. The other is direct care staffing, FTEs. You know, there are two. I'm wondering whether there's duplication. You know, there is already the CMS PVJ reporting process, and so that information is available. In addition, OHCQ has a 3.0 hours per license per occupied bed standard. Maryland is at the forefront in what states do in this area by counting RNs, LPNs, aides, and other support staff. And so I just am concerned about creating an additional and potentially conflicting reporting requirement when we already have federal and state data on staffing. I'm not suggesting is a way to avoid disclosing the information. I'm just saying this opens the door to reporting and data counting and calculations that are different from the robust reporting mechanisms that are already there. And the other thing I will point out is there is a problem. Just again, you may want to benefit from a conversation with somebody with a financial background, and because it's easy to throw around the term audited financial statement, which is a CPA accounting principles term of art. There's always a startup standalone entity when whether it's a for-profit or a not-for-profit or whomever is acquiring a facility, creates an entity for that purpose. There's nothing suspicious or nefarious about that. That's the way it's always done. Brand new entities really are not in a position to produce audited financial statements because they're startup entities. Now, that doesn't mean that you don't collect financial information, and that is part of the process. But I would just suggest that you, again, avoid running into a problem with not being able to attract responsible acquiring entities by requiring an audited financial statement for an entity that in good faith, and just because it's a brand new entity, is not going to be produced one. I think the question is there enough money invested and resources preserved to deliver effective care, and what the period of time is that you want to measure and make sure that financial house is in order. I'm not getting into that. I'm just saying, I just think it's important to be careful on these particular recommendations. Thanks.
And were you trying to make a comment? Anna Palmisano, you have your hand up.
Yes, thank you. I'd like to add another metric, which would be the ratio of direct care workers to patients. I've heard so many horror stories from care workers, patients, and their families of care workers having to juggle as many as 25 nursing patients that really need a lot of help. That's just not acceptable. And I don't think that ratio is not reflected in that list. So that's my suggestion. Thank you.
One thing that somebody from OHCQ may comment on is Maryland has strict requirements in terms of clinical staff ratios for numbers of patients, and there is a regulation on that issue. I'm not suggesting everybody, but Maryland does regulate in that area. I'm not suggesting there aren't problems. That I'm not trying to explain it away. I'm just pointing out that there is a state law on care workers to resident ratios.
All the more reason to include it on the list, I think. Thanks.
Correct. Yes, Stevan has a question in the chat.
Stevan's question is, what would be considered related to facility performance? and what data would be reviewed and what would be the source of the data.
Related. What data will be reviewed?
Where does it say related data facility performance? Stefan,
I'm looking at the acquiring entity shall submit the above information in the form of the end of year financial statements. The statement should compare the facility performance to its operating budget. So that's what I was asking about. What's the facility performance? What are you using to determine what that is?
oh, so how the facility actually performed financially compared to what it was budgeted to perform for the operations.
Okay, and I was asking that because it says it has money and care combined in these bullets A through F. So, and I'm talking about care, meaning total direct care staffing FTE. So I was in hours of bedside care per day. So I didn't know if other things were going to be considered or if it was just E and F that were going to be considered. And then an aside is I think that any information to talk about who's providing care, because bedside care in some facilities, the way the COMAR reads, and I don't have the regulation in front of me, is people that are laying hands on people in the Maryland regulations. So I think it would be helpful to say who is providing the bedside care. Are they including the nurse that's providing care in the aid, or are they also including, I think it was Howard Solins that mentioned all these other people that actually don't lay hands on people most of the time. So anyway, that's what my questions were related to.
Okay.
I'm sorry, just to be clear, they all do provide care. It's just that they may be nursing, they may be therapy staff. There's a defined list of categories.
Tracy,
You can have Senator Vidal and then
Senator Vidal has her hand up.
Trouble. There we go. Thank you. Listening to Stevan, one of the things that in 2021, we passed a bill that said when there was a transfer of ownership for a new company coming into Maryland, that there would be a survey within the first 3 months and then a follow-up like 4 months later. So I think as we look at post-acquisition, we haven't really used the term survey, but going in and looking at the facility and how the people are cared for and surveying the families, it should really be done shortly after any acquisition within the first few months to make sure things are running smoothly. Was that considered at all in the discussions?
Yeah. We have it as a separate recommendation. Let me tell you which number it is.
it's
It's number 7. We have the recommendations for the Department of Health included as recommendation number 7.
I'm sorry, I missed that. I had a lot of reading this weekend. I didn't get to that one. Thank you.
That's okay. That's fine.
And Claudia Bela, you have your hand up.
Yeah, just a couple of things. Number one, sorry, I've been ill. I appreciate Senator Bidles raising the issue of the accuracy of all of the information. And sort of in my mind, I've been sort of carving out pieces of this whole puzzle. And, to the extent that I think that, these recommendations are for the MHCC and ultimately OHSQ to use whatever data is available. And we do have to address the accuracy of, say, cost reports, but I don't know that this has been the forum for it, but I really appreciate that conversation. Number 2, to Howard's point, I didn't read the recommendations as precluding the ability to use PBJ data to provide sort of a top line analysis of direct care staffing. So I just wanted to note that because I do agree that PBJ data is probably the best source. And I don't read this as asking facilities to kind of come up with a whole separate set of numbers, but the idea here, and I think to Stevan's point, is like, what can we cull from the various resources that we have to create a report that really dives into what a facility's performance looks like in the years following an acquisition. And I like the addition of a third year. And can I just throw in, I know you were going to have an opportunity to discuss people's comments on this section, but since I'm talking, can I just go ahead and just add that? So the one addition I did make to this section, because I think it kind of gets to all of it, is you know, we're looking at operating revenue and operating expenses. And I actually agree, Howard. I think that we can kind of drill down much further on like what numbers we're actually looking at. I wanted to add a third letter bullet, which would be an analysis of direct care spending. And different states do this in different ways. But really just looking at the total number, the value of the expenses spent on direct care, and that can be staffing, that could be housekeeping supplies, it could be all of the things that are sort of generally generated in a list of what constitutes direct care, and what is the percentage of the budget for these facilities that's being spent on direct care. Because I do think that, you know, Maryland operates in a RUG system. We know broadly that, you know, cost centers such as paying workers are high, but what is that number? Massachusetts has something called a direct care cost quotient, where the state is looking and seeing how much of these public dollars, because you could drill it down to Medicaid per diem, how much of these public dollars are being spent on the things that ultimately impact resident care in the facilities. So I would, and again, we can like talk about like what the metrics are and what the numbers we include are to do that. But I think it's really valuable to not only know, is this facility in the black or in the red, but okay, and not only know like, okay, well, what does staffing look like, but how much of the revenue that it's generating is being targeted to direct care.
Thank you. I did want to also, we had one other comment that was from Ann McKay, and she made the suggestion that we could consider providing data on occupancy levels, length of stay, percent of hospital admissions / readmissions, and percent return to independent and assisted living. I think that one in particular just would refer mostly with the CCRCs. But I just wanted to have her comment as well.
Yeah, those recommendations came out of from MACRA, the executive committee. I think that, you know, occupancy levels are a barometer of the health of a community. And, you know, rehospitalizations, I think there's been research, and I think we discussed it at this, in the work group, about an increase in rehospitalizations is also an indicator of quality. And that's why we suggested there be some additions there.
Thank you. Tracy?
Yeah, two comments. I appreciate sort of, I guess, Howard and Claudia's comments about getting information from third parties, but I really sort of think that is more to check the information against which the purchaser or the new owner is providing to us. So I think it's beneficial to get firsthand information as they're providing it. And then in addition, I would think if they fail to provide it, that MHCC should have some ability to impose a financial penalty. And at this time, I do not believe our statute allows for that direct authority.
Thank you, Tracy.
Oh, it is? Oh, I stand corrected. Apparently it might be in our statute that we could do that. But I think that that would be a good addition to that recommendation. Thank you.
Any other? Okay, I don't see any additional hands or chats. On to number 4. The next few recommendations would require statutory changes for MHCC. It's fine. The commission shall request the legislature to expand MHCC's authority to deny an acquisition based on quality metrics and other standards required in the certificate of need reviews to align CON quality standards with nursing home acquisition regulations.
We did receive one comment on this one, and it did come from Anna Palmisano. Anna, did you want to share your comment?
You know, I understand why you would want to align it exactly with Comar 1024-2005-8, but in reading that, regulation, the bar is pretty low. Only 70% need to have an average rating of 3 stars. Anyway, it concerns me. I would like to think we could aim higher to protect patients. This may be a bigger issue than our discussion today.
Yeah, I think that this has been, Stefan. We are simultaneously looking at that standard. It was developed before the pandemic, and I've previously said that it did have some unintended consequences. I would think that we don't want to make it even more difficult, given the performance over the last 3 years, which has declined as a result of exogenous factors at a lot of facilities. But I think it's important to say that while we want to rethink it, we don't want to completely abandon it. And there's probably more nuancing of a standard like this will be necessary going forward than we put this in place in 2018 and 2019. We had very good intentions and thought the stability of the measures was a little greater than we've seen over the last couple of years.
Ann McKay has her hand up.
Well, I would certainly support this recommendation because, finding out that some 1-star operators are now in the state, that's a little disturbing. And I would support anything that would tie ownership to quality. Over the weekend, it's been quite distressing reading articles about some of the operators that are now in Maryland that own over 100 facilities, and what's happened after they buy a facility and what they do and how they get their money out of it. It's quite disturbing.
Thank you. Erin Davis has her hand up.
Hi, thank you. This is Erin Davis with Maryland Hospital Association. One of the things that we believe is important when looking, comparing this to the certificate of need standards is when we look at certificate of need, we look at the benefit to the community and the services that will be provided. And I think that's important that we keep that in line because we do struggle with hospital throughput, and we want to make sure that we meet the needs of the community in their skilled nursing needs, post-hospitalization, and in long-term care, and want to make sure that services that are needed by the community, including our complex patients with dialysis and vent needs and things like that, that those beds aren't changed.
Joe DeMatos.
Hey, I just want to thank you. Appreciate it. I just want to make a general comment that I have appreciated the dialogue today, and I want to commend the MHCC staff for the way that they've led the work on this working group. I say that because I just want to make a general comment as we go through the report, the draft report, and then ultimately issue the report, and then take what's necessary legislative and other government action to advance our work on really three key issues, and that is continued access to quality care. How do we ensure quality care with transparency, and understanding the important role that workforce plays in all of that? So when I see all of these recommendations, that's what I'm thinking about relative to Erin's points. I'm thinking about continued access to care and getting people out of the hospitals, and if they need to, into nursing homes before they go home stronger. And I'm thinking about the workers that provide that care. So so I commend the staff for their work on this. Two last points, and that is I think an important step going forward will be to look at what's in the various sort of regulations out there today. I mean, even on this call, people have been sort of unaware of some of the specifics and nuances of existing regulation, and we've been at this for many months. So looking what's there, how are we going to make it better? Where are the gaps? And then not to forget that policies have consequences. And sometimes those consequences are intended, sometimes they're unattended. And we have to work together on that. So I commend the staff. I really have enjoyed the conversation today, and I didn't want the meeting to end without chiming in and thanking everybody today for their comments, but especially the staff to getting us to this point. So thank you, Ben and staff.
Thank you. Anybody in the room? Ben, do you have something?
So I wanted to, go back to, post-acquisition recommendations. I thought the ideas there, that people offered were really good. And I think, what we started with was really building off of some recommendations that, Bob Kramer made when he presented to the, folks, to the work group in, I guess it was late August. But about that time anyway, but I think we want to take those specific metrics and think about the recommendation and maybe make it a little more, I think as Howard said, rational with regard to the financial measures we're asking for, but also enrich it with some of the utilization measures that we are monitoring under the total cost of care. To Erin's point, we have a new operator theoretically, and an opportunity for them to become acquainted with how things work in Maryland might be a benefit to that recommendation, and asking them to report to the commission on how they're doing on metrics that both CMS and the state believe are important as we try to meet the new requirements under the model for skilled nursing facilities. I probably qualify that specifically, there are not specific requirements, but aspirations.
Noted them. Thank you. Any other comments on 3 or 4? Recommendation 5. The commission shall request the legislature to expand MHCC's authority to increase the timeframe that the acquiring owner must submit all required documents to the commission to 45 days prior to the transaction closing. MHCC staff will complete its review within 45 days of receiving a complete notice of acquisition, transfer of ownership, interest of a comprehensive care facility.
We did not receive any comments to recommendation number 5, but can pause here to see if anyone on the call has comments that they want to enter for recommendation number 5.
I am not seeing any additional comments. Still nothing. Okay. We will move to number 6. The commission shall request the legislature to expand MHCC's authority to require an acquiring entity of a nursing home to eliminate or reduce to the maximum extent possible the number of multiple bedrooms within 3 years from the acquisition date. These transitions shall be incremental and implemented with appropriate planning.
So we did have a couple of comments that were entered on recommendation number 6. The first one was from Anna Palmisano. Anna, did you want to make your comment?
I think you've really addressed my concern there because I didn't want it to be, I wanted a stepwise change, not a catastrophic one that would negatively impact the nursing home residents. But I would like to see something in there that they're developing, the owners are developing some kind of strategy so that it to really make sure that it is incremental instead of a sudden change. And I didn't really see that language. Are there going to be periodic reviews to assess that they're making progress towards this goal? I guess I'd like to see a little more clarity there. Thanks.
Paul Miller, we see that your hand is up.
Yeah, thank you. It's Paul Miller from Lifespan. I have a couple general comments about recommendation 6. I see a few difficulties with this, and perhaps we need to look into ways of making it easier for facilities to relocate. At the current time, the comment was made about an operator moving bed to another facility of theirs. At this point, you can't move them across state lines. So that is the county line. So that is a difficulty. So I think we need to revisit some of the other items that may encourage facilities to either relocate beds, make improvements. The other item that gives me a concern relates to recommendation 1 tied into recommendation 6 and has to do with MOU. The MOU is an outdated concept. It was fine when statewide occupancy was in the mid-90s, but we are nowhere near that and haven't been for many, many, many years. If a facility chooses to de-license beds, I think we are putting them in a position that they may have difficulty meeting their MOU requirements, and I don't feel they should be penalized because of that. Thank you.
Thank you. And Lou Grimmel, you have your hand up.
I do. This language lacks clarity and direction. Instead, MHCC should lay out a clear requirement that acquiring facilities take affirmative action to eliminate no less than 10% of its multiple bedrooms within the 3 years of acquisition date.
Tracy?
I had a question for, I guess the gentleman that said that the MOU with Medicaid is outdated. I wasn't clear as to why.
Paul, do you want to explain? Paul?
MOU is outdated because we're no longer having facilities turn down residents because they don't have beds. We're only running under 90% occupied. So they are taking Medicaid residents, gladly taking Medicaid residents. If you reduce their number of licensed beds and they have to choose on what payer type to put in, they may choose not to take that Medicaid. So it's not an issue now, but as licenses go down, licensed beds go down, it could become an issue again. With the growth of assisted living and money follows the person, we're just seeing less occupancy, and I don't picture that or see that changing in the near future.
And when Paul's done, there, can I offer a comment? It's Howard.
Yeah. Thank you. Thank you.
Howard, do you want to
I'm
make
done,
your
Howard.
comment?
All right, two things. This is maybe just obvious to everybody but me. We're using the phrase multiple bedded rooms. 2-bedded rooms are multiple bedded rooms. I just want to make sure that the recommendation, that whatever the outcome is, that we're talking about 3 and 4-bedded rooms. I know the aspiration is all private all the time, unless people choose to share a room. But I just think, recommendations can sometimes be read in different ways. So I would just suggest that there be some parenthetical definition. With respect to the MOU, to build on what Paul said, a Medicaid occupant, we're not talking about a requirement to participate in Medicaid. We're talking about a requirement to attain and maintain a specific level of Medicaid occupancy, which is completely counterintuitive to anybody who supports Olmstead and the efforts to develop non-Medicaid institutional Medicaid occupancy, because you're creating what out of an outdated concern about inability of Medicaid beneficiaries to secure a bed. You're creating an incentive. I don't think anybody would not discharge somebody because they need to make sure that they comply with their MOU, but it is a counterintuitive policy to say that you want to attain and maintain a certain level of Medicaid occupancy. The commission recognized that some years ago with a 15% offset in the calculation, but I think that there's a fundamental, and as a matter of fact, I recall during the debates that now I don't know what the current Medicaid agency's authority or position is, that the Medicaid agency was not in favor of a specific MOU requirement mandating that you make sure that you have a certain percentage of Medicaid occupancy. So I agree with Paul that it's outdated and is contrary to an Olmstead philosophy of care.
Thank you.
Paul, do you still have your hand up, or was that from previous?
That was previous.
Okay, thank you.
Don't see any further hands up for anything in the chat.
Oh, I have one more for number 6.
Oh,
I'm sorry.
Sorry.
One more comment for number 6 that was submitted by Ann McKay. She says that we should add maintaining current occupancy levels and not result in the displacement of current or future occupants as it relates to facilities within or affiliated with continuing care retirement communities.
Are there any further comments? Move to number 7.
So before, I didn't really understand Ann's change. Can she comment on that?
Ann McKay, can you comment on your comment?
Yeah, I think the concern expressed there is that people that were in independent living would still have the opportunity to access skilled nursing if needed in their community.
Thank you.
But I don't know if there are CCRCs that do have 3 or 4 bed rooms actually.
James Forsyth has his hand up.
Yeah, hi. I'm not sure if I heard correctly because my connection's been going in or out. But let me just say, to the extent anyone is suggesting this commission should hold back on recommendation 6 because it would result in a reduction in Medicaid patient days, if anybody's arguing that, I just want to say I think that's appalling. That is essentially calling for Medicaid patient days to be generated in triple and quad bedrooms, which, that's clearly a multi-tiered system. If you're on Medicaid, we're just going to put you in what the commission already considers to be substandard environments. So I'm not a member of the work group, and I do appreciate the opportunity to offer comments now and then. And that's my comment for today. Thank you.
Thank you. Joe DeMatos, you have your hand up?
Yeah, just real quick. I don't think, to the previous comments, I don't think anybody is making that suggestion. And you know, the vast majority of people who are in Maryland nursing homes, regardless of the payer source, and certainly on Medicaid, are not in triples and quad rooms, right? The vast majority of all residents and patients are largely in double rooms. So I appreciate the passion of the previous commenter, and just wanted to clarify that I don't think anybody is making that suggestion, and to point out the obvious again, that the vast majority of people in nursing homes, regardless of the payer source, they're in double rooms.
Thank you. Were there any further comments? On to number 7. This is a recommendation for the Department of Health. OHCQ shall implement the current statutory requirements set forth in the Health General 19-1408 by conducting a full survey within 3 months after the date of transfer, followed by an unannounced follow-up for any deficiencies within 120 days. OHCQ shall report the findings of the survey to the Commission and the public. Any written comments?
No written comments for recommendation number 7.
Is this the one Senator Bidle?
This is fully implementing the 2021 law.
Right.
Correct.
Any comments from OHCQ?
Joe DeMatos, do you still have your hand up or do you have a new comment?
Let me take that down. No new comment.
Very good.
Paul Masano has her hand up.
Yes, and I hope Dr. Trichet is still on the phone there. My question is, does OHCQ have the resources and personnel that are needed to accomplish the oversight of these surveys? Or is this going to be viewed by you all as an unfunded mandate? I know that in the past, you've talked about being more responsive to complaints, but this is one situation where you may have to be more proactive. So I just like your view on, again, whether or not you have the resources and personnel to accomplish that.
This is Tricia Ney with OHCQ. So Anna, this was an unfunded mandate. We need between 5 and 6 full-time surveyors and a coordinator to conduct these activities. And so we haven't been able to do it because we do not have the surveyors to perform those activities.
Senator Bidle, you have your hand up.
I do. Thank you. Thank you, Dr. Ney. I had a meeting with Dr. Ney earlier this year and learned that we didn't have the resources. And Anna, I followed up with the Department of Budget and with the Secretary of Health and asked that these surveyors be funded in the next budget. So we're trying to get that done this current budget year. Thank you.
Thank you.
Excuse me, Stevan has a comment in the meeting chat, and it's just for consideration. Most of the residents that she has spoken with in triple and quad rooms would prefer to be in a semi-private or a private room. They lack privacy and it is not a home-like environment.
Thank you. Tracy.
So for this recommendation, I would suggest maybe we put that in, that recommendation about, and be very specific, a coordinator and then 5 surveyors to do this particular task. And then, I don't think we need to worry about how much that might cost though. I mean, we should know, but okay, not including that in the recommendation, but just that recommendation that
Thank you. Are there any further comments?
General.
Okay, there are a few general written comments that we received.
We do have a few general comments that, not for any particular recommendation. I believe these mostly came from you, from Anna Palmisano. Anna, did you want to reiterate your comments here? Or I can read them if you want.
No, no, you actually, I was able to cover my issue and I appreciate Senator Bidel addressing that as well. So thank you very much.
Okay.
Thank you. Anything further for recommendation 7? All right, we'll move on to 8. This is a recommendation for the Office of the Attorney General. The Office of the Attorney General shall continue to evaluate their authority to play a role in the acquisition process.
So we don't have a specific recommendation at this point, but I think given the Office of the Attorney General's interest in this, we would continue to ask them to explore ways in which their authority could be focused into this area.
Tracy?
I think one of the areas to look at for them might be the area of disclosure. Something specific, but I totally left my brain, but I think in the area of disclosure of information, more specific later, sorry, lost my train of thought. Thank you.
Are there any comments or questions regarding this one? Okay.
Shelley Martin just raised her hand.
Okay, Shelley Martin, you have your hand up.
Yes, so in the way this is written, as far as our office is concerned, I think that right now we don't have any existing authority to play a role in this process. So it's not clear to us like how we would continue to evaluate that. If there are specific areas that, you know, for the future should be considered for things that potentially the OAG could do, we could consider that. But right now we just don't have a role in the process.
Thank you.
Can you elaborate a little bit? This is Tracy. Can you be specific, Shelley?
Well, I mean, right now, the statute does not give the OAG any role in the process when a nursing home is acquired. So, you know, could it in the future potentially, but that's not really something that our office has considered before. And if there are specific, like I said, if there's specific things, we could certainly consider that in the future. But I mean, as of now, our office is just not a part of that process.
Worded differently so that it's more acceptable to you. I think the ideal here is that would be good to have your office play a role in this. We don't know exactly what that is at this point, but will we rework it a bit?
Yeah, I mean, I think that, you know, if there should be consideration of whether the OAG should play a role, that's fine. But as of now, we don't. So.
Anne McKay, did you have a question or comment?
Yes, my comment is, would there be a role for the OAG to look at lawsuits that have been filed against prospective buyers or number of fines that they have received in other facilities? Or would that be handled by MHCC?
I would think that we could, as part of the assessment that would occur prior to acquisition, that's what I don't think there's a need to duplicate that. I think we could conduct that examination as part of our process of vetting a prospective acquisition.
Is that part of the process now?
Yes.
Yes.
Thank you.
I don't see any further questions or comments. So the tentative next steps, thank you very much for the great conversation and the great additional comments and things to think about. We will distribute a final draft back to the work group by November 17th, and then your feedback will be due by November 29th. Then we will prepare to present to the commission on December 14th so that we can submit the report to the legislature by the early next year. Are there any final comments or suggestions before we? No?
This is Howard Solomon. So I just want to, again, compliment the atmosphere and the respectful airing of views on this. There's an expression we use in our family, and I'm sure other people use it as well. Expect a certain behavior and you'll get it. Sometimes, you know, I know that there have been references to 5-star, which is a flawed tool, the existence of lawsuits, which may or may not be meritorious, may or may not be acceptable. I think at the end of the day, everybody agrees that you want to attract into Maryland operators who people feel comfortable with. And I know that this is an effort to try and put some metrics on that and establish that process. I would just suggest that as we go forward, that we think about the question of what the result is, because there are situations in which you can create an environment in which the operators that you want to come to the state will not come to the state if the process is overly problematic. That doesn't mean you turn a blind eye. It doesn't mean that I'm happy to get into a separate discussion with anybody who's interested and willing about why facilities end up with 1, 2, 3, or 4 or 5-star rankings. That's not for this conversation. But all I'm saying is that all of this, I think, should be through a lens of what are situations in which we want to bring in people who are going to operate, invest resources, make sure resident care is provided in the appropriate way, and facilities and residents get the staff support that they need. I think there's no doubt that should be a goal. I would just suggest that you need to look at specific regulations through that overall lens.
Thank you, Howard. I just wanted to respond to that. I think, we couldn't disagree that we want to attract capable, high quality purchasers to the state. I think the main drivers of that are the market environment here, which a number of observers have emphasized as an attractive environment for purchasers. Given that situation, I think we can say we want to use the regulatory structure to make sure that we amplify the selectivity from the standpoint of the state, and trying to promote good character among operators. And I think there are market factors that make this a very attractive environment, and will continue to be so, given the low Medicare Advantage penetration, the relatively attractive Medicaid reimbursement, as well as the general more affluent senior population, all contribute to making Maryland pretty attractive. And I think we can use that to our advantage as we try to shape who else comes into the state. So I agree with your comments about always being mindful of metrics that may not do what they were intended to do. But I think we should definitely not shirk from our responsibility, nor should we ignore the fact that the Maryland market, at least currently and for the foreseeable future, is probably attractive for purchasers.
Yeah. Any final comments?
And McKay has her hand.
McKay, you have your hand up?
No, I was just giving a thumbs up to Ben's last comment.
Okay, thank you. All right, well, if there are no further comments, I thank you all very much and we will be in touch soon. Thank you.
Thank you all.
Thank you, Senator.
Thank you, Senator.
Thank you.